everyone. Thank you for this opportunity. Today I'm going to be presenting our study on the efficacy and safety of the addition of oral metronomic chemotherapy in patients with locally advanced esophageal and gastroesophageal junction squamous cell carcinoma who have completed standard chemoradiation. So as we know, the current standard of care for patients with locally advanced squamous cell esophageal carcinoma who are not amenable for surgery is chemoradiation. This was established more than 20 years ago by the RTOG 8501 study, which showed that the addition of chemotherapy to radiation significantly improved outcomes, and the median overall survival in this study was 14 months with a 5-year overall survival of 27%. Over the years, there has been a marginal improvement in outcomes in this subgroup, mostly with the addition of supportive care. However, multiple strategies over the years to improve outcomes in this subset have failed, and it is an unmet need. Metronomic chemotherapy has activity in various settings in head and neck cancer, and it showed promise in esophageal cancer. Hence, we decided to conduct this study. This is a study design. It was initially designed as a phase 2, phase 3 study. We are reporting the phase 2 results here. This was an open label study which included patients with squamous cell carcinoma of the esophagus or G junction who had completed definitive chemoradiation within 12 weeks of completion and who had an ECOG performance status of 0 to 2 without any evidence of progression with adequate marrow and organ function. The primary endpoint for the phase 2 part was progression-free survival, and secondary endpoints were toxicity and overall survival. Patients were randomized 1:1 to either receive metronomic chemotherapy or to observation. Metronomic chemotherapy consisted of celecoxib 200 milligrams, which was given twice daily, with methotrexate, which was given 15 milligrams per meter square once a week. And these patients were followed up every 3 months in the first year and then 3 to 6 months. These are the baseline characteristics. This is balanced in both arms. Just to highlight 3 points, that most of the patients in both the arms had upper thoracic esophageal cancer. Most of the patients had stage 3 disease, and around 90% of them received paclitaxel carboplatin concurrent with radiation. 46 patients out of 75 patients in the metronomic arm completed all the 12 months of metronomic adjuvant chemotherapy. 22 patients in the metronomic chemotherapy arm had to discontinue because of disease progression before 1 year. Progression-free survival was the primary endpoint. And if you can see on this Kaplan-Meier on the left, the median progression-free survival for the metronomic therapy arm was only 23 months, with observation arm where it was not reached, and the hazard ratio was 1.33. The blue line is the observation arm, the red line is the metronomic chemotherapy arm. And then, as you can see, at both 1 year and 2 years, the survival in the observation arm was significantly better than the metronomic chemotherapy arm. According to the statistical plan, the study would not move forward if the p-value crossed 0.2, and this did not meet its endpoint because here the p-value was 0.22. This is the forest plot which shows the progression-free survival across various subgroups analyzed, and even in all the subgroups, there was no advantage with adding metronomic adjuvant chemotherapy after chemoradiation. Secondary endpoints were toxicity and overall survival. The Kaplan-Meier on the right shows overall survival. Similarly, just like progression-free survival, here the observation arm did better than those who received metronomic chemotherapy, with the median overall survival of 36 months in the observation arm versus not reached in the 36 months in the metronomic arm, and it was not reached in the observation arm. There was a significant difference in the 2-year overall survival. In the observation arm, 75% of the patients were alive, whereas it was only 54% in the metronomic chemotherapy arm. And out of the 56 deaths in both the arms, there were 34 in the metronomic arm and 22 in the observation arm, and 46 out of the 56 deaths in both arms are related to disease progression. Toxicity was not significant in the metronomic chemotherapy arm. It was the incidence of grade 1 and 2 were low, as well as there was no difference in grade 3 or 4 adverse events in both the arms. To conclude, metronomic chemotherapy did not delay relapse or improve survival in patients with esophageal squamous cell carcinoma after chemoradiation. There are some reasons which we thought would have impacted the results of our study. One was patient selection, whether we selected an appropriate cohort of patients, because we selected patients who had not progressed after 3 months, which could mean they were a very good subset with a good disease biology and may not have benefited from this therapy. Our timing was empirical. We started around median time to start the metronomic therapy was 11 weeks after radiation. Whether this was an appropriate timing or whether it should have started earlier is a question. The choice of the drugs was largely empirical based on our experience in head and neck cancers. We did not have any biomarker directed therapy. And also the histology per se, whether squamous cell histology had a negative impact on the outcomes is another question that is unanswered. Our study had some limitations. It was a single center study. Unexpectedly, we had a better PFS and OS than reported literature, and as compared to what we had made assumptions for, and hence it was unexpectedly underpowered. The choice, as I already mentioned, the drugs was empirical, and we did not do biomarker studies. To conclude, adjuvant metronomic therapy with methotrexate and celecoxib did not prolong time to disease recurrence or death in esophageal squamous cell carcinoma after radical chemoradiation. Thank you.